From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA podcast. I'm Dr. Kirsten Bibbins-Domingo, and I'm the editor-in-chief of JAMA and the JAMA Network. I'm joined today by Dr. John Wong. He's a primary care physician in the Department of Medicine at Tufts Medical Center, where he's also the Vice Chair for Academic Affairs and the Chief of the Division of Clinical Decision-Making. Dr. Wong is a professor of medicine at Tufts University School of Medicine and a master of the American College of Physicians. Dr. Wong is also a member of the U.S. Preventive Services Task Force, and he's joining us today to discuss the new recommendation statement from the task force on pre-exposure prophylaxis to prevent acquisition of HIV. JAMA has published this recommendation statement and the evidence report on which the task force based its recommendation. Thank you, Dr. Wong, for joining me today.
Glad to be with you, Dr. Bibbins-Domingo.
Wonderful, wonderful. So why don't we begin, as we usually do, with just a high-level summary of this recommendation? What's the big takeaway message?
The takeaway is that we, the task force, continue to recommend that clinicians prescribe pre-exposure prophylaxis, commonly referred to as PrEP, to people at increased risk of HIV to help prevent HIV.
Wonderful. And give me the grade. What grade does this one get?
Yes. It's a grade A, which is, as you know, our strongest and our highest recommendation.
Wonderful. So an A usually means that we do have an evidence base. We have a set of studies to look at. That evidence base is robust and compelling, and the evidence tells us that the benefits are substantial and they outweigh any risk. What do we know about PrEP? You're asking somebody to take essentially a medication in order to prevent HIV. How does the evidence base tell us that the benefits here outweigh the risk?
So let me start with the evidence base. We have randomized controlled trials, which you know are the very pinnacle of evidence, and that involves over 35,000 patients who entered those trials. So we have strong, solid evidence that PrEP can prevent HIV. An important part of that is that PrEP is most effective when taken as prescribed. Now, if you put that in context for the harms, we find that there are some harms that include renal or gastrointestinal adverse effects, sometimes weight gain, and with the injection form of PrEP, which is one of the new developments since 2019, you can sometimes get injection site reactions due to the shot. When you think about the possibility of getting HIV, which, although it is treatable, we know that it's not curable, and we know that it can have lifelong consequences for health. And although there are some adverse effects, when you balance that out, we find that there's substantial benefit. And we would recommend PrEP for those individuals who are at increased risk for HIV.
Wonderful. That's such a great explanation of the evidence base. But I want to focus in on two things. One, this recommendation applies to people who are at increased risk. So tell us a little bit more about who we might consider at increased risk.
It's based on factors that increase a person's risk for HIV. Those are due to activities such as having sex with someone who has known HIV, having had a recent sexually transmitted infection, not consistently using condoms, especially with a sex partner who is at increased risk, and also sharing drug use, needles, syringes, or other equipment. Those are factors that place an individual at increased risk and would make them eligible for PrEP.
How big a public health problem is HIV? How many are infected and how many do we think are at risk for infection?
So we have about 1.2 million individuals in the United States with HIV. And every year, at least in 2020, we had over 30,000 new infections. And we want people to know that HIV can be prevented. And part of that is medications to supplement the use of condoms consistently and safer sex behaviors.
So we're going to drill down a little bit on that, but I want to make sure I get back to the point that you mentioned that since the last time the task force addressed this issue, there are additional regimens for which there's evidence that they're effective for preventing HIV acquisition. So talk to us about how one takes PrEP, what forms.
This is a really important development, and it's the most important one for us to provide an early recommendation statement for PrEP. We had an older version that was oral. We now have a second oral version. But most importantly, we now have an injection form that I mentioned earlier. And what's important about that is that it gives patients options to choose a formulation that they are most likely to take. And we know that the PrEP is most effective when taken as prescribed.
Oftentimes, more options are effective for helping patients and clinicians choose the one that's best for them. So it sounds like in this case, given that you have evidence for the newer options, that will help ideally with the uptake.
Yes, and it's key for clinicians to have that conversation with the patient, to work with them to decide, would you be happier taking a medication by mouth on a daily basis, or would you be happier taking an injection first every month for 2 months and then every 2 months? And I'll just say in my practice, I have patients who say, Doc, I really don't like needles. I would much rather take the pill. But I also have patients that say, I have trouble remembering to take a pill on a daily basis. And perhaps the shot would be right for me because I can just take it every month initially and then every other month. And I don't have to worry about it on a daily basis.
When we first started having conversations about PrEP, there were many who were worried that taking these types of medications would actually encourage continued at-risk behavior. And there was concern that use of these medications is not compatible with our goals for prevention. How would you or the task force think about those concerns?
Thanks, Kirsten. We recognize that potential harm, and our evidence-based practice center looked at the randomized controlled trials for evidence of increased risk for infections due to perhaps increased activity based on the confidence that they were taking PrEP. We do not find any signal that shows us that there's a statistically significant increased risk for those sexually transmitted infections. But we do call for additional research because we do know that those studies were done in a randomized controlled trial setting. And we would like to know longer term if we see any increased signal coming from other studies.
Wonderful. So you talked about your own practice. What's your advice to clinicians? What types of questions should we be asking our patients to see if there's someone who might benefit from PrEP?
This is a key first step, and it starts with having an open, trustworthy relationship with patients. What's key is making these questions a routine part of clinical interactions, phrasing the questions in an open and transparent way, and emphasizing that this is a routine question. So I will ask about sexual activity, and I will ask about a history of drug use. And patients will answer, and if they have some question about, well, why are you asking me about that? I'll respond that it's a routine part of my questions for patients because my goal is to keep you healthy. And these are certain activities which will help direct me towards interventions that can keep you healthy.
That's great. One of the things the task force has historically done well is to help clinicians to have these conversations with patients. But one of our goals, certainly here at JAMA, and I know of the task force, is to make sure we're also talking directly to patients and educating patients. So if a patient comes in and asks for PrEP, how should we, you and I as primary care physicians, take the request coming directly from patients, as it often does now?
Yes, there is that possibility that they may directly ask for PrEP. I'll just say that the task force recommendation statement is explicit about identifying those individuals who are at increased risk. And by a patient asking for PrEP, they may not be comfortable with divulging what their risk factor actually is. And I will gently ask, because that information may help me determine other interventions that could be of benefit to the patient. The task force does ask for that increased risk. However, I do recognize that for some of my patients, that is a sensitive topic. So I want to be clear with them why identifying those increased risks are important for determining the balance of benefits and harms. So I want them to have knowledge about the potential benefits. I want them to have knowledge in particular about the harms and the role that the risk for HIV infection plays in that because of the harms. If they still wish to have the prescription, I've imparted to them knowledge about the benefits and harms. They likely have clarity about their risk as well as how they view the benefit and harms. And in those situations, I'll work with my patient, and in all likelihood, I would prescribe it.
So it sounds like in the ideal world, educating patients, educating clinicians will allow us to have that conversation together, regardless of where the request or who prompts the initial discussion, whether it's something that is done routinely on the part of the clinician or if a patient initiates the conversation. The goal here is to have a little more information so as clinicians we can take the best care of the whole patient for other things that they may be at risk for, but that given the strong benefit that the task force is finding in the evidence for the use of PrEP to prevent acquisition of HIV in those at increased risk, if that person is found to be at increased risk after those conversations, that PrEP is the answer.
I fully agree with that. And as you know, the task force has a statement about shared decision making, and that is sharing our professional knowledge about harms and benefits. And again, in this particular recommendation statement, it's a grade A, so we have strong evidence for the benefit to harm ratio. And I'm expecting or hoping that this willingness to prescribe PrEP can lead to a trusting relationship with the patient going forward.
Wonderful. So any last words that you'd like to leave us with to underscore the important points in this recommendation?
Yeah, I think I will go back to our recommendation statement that, we have a recommendation that clinicians prescribe pre-exposure prophylaxis, commonly referred to PrEP, to people at increased risk of HIV to help prevent HIV. It's a safe, highly effective preventive medication, and obviously HIV is a serious public health issue, and encourage clinicians to do the work needed with their patients to ask and work with them to identify who's at risk and to recommend the PrEP for those at increased risk.
Thank you so much, John. This has been such a great and clear discussion. I've been speaking with Dr. John Wong, an internist and primary care provider and member of the U.S. Preventive Services Task Force, about the new task force recommendation on pre-exposure prophylaxis, or PrEP, to prevent the acquisition of HIV. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.